Scott. And in the interest of full disclosure, as Dr. Zafar started the day, I too didn't make it. I didn't have a tie make it into my bag either. But the difference between us is that my daughter lives here and my wife accompanied me, and so I offer this as evidence that I married well. So, maybe we're going to finish today's session because at one point the work that I'm going to describe was described as a death panel. And I'm hopefully we'll see that that's not actually what we were up to. But I'm a medical oncologist. I'm actually a token medical oncologist on this panel, I guess. I've been in private practice for the last 20 years in Portland and the last 12 or 13 years leading a large medical oncology group of 43 doctors. And in the last 8 months, I've been in a fully administrative role with Providence Health System. But I'm here today actually to talk about the work that I participated in as a member of the Oregon Health Evidence Review Commission. And that's really an organization that was formed to help us oversee the Oregon Health Plan, which is our version of Medicaid. And while many in this room probably could talk more eloquently than me about Medicaid, it's also not surprising that a lot of folks don't really understand exactly how Medicaid works. This slide I put up here mostly to demonstrate that there's complexity here. Medicaid is a program administered by states, but funded by a number of different sources, and there's strings attached as a result of all of that. It has different faces depending on which kind of a provider you are. So for instance, if you're an OB/GYN provider in Oregon, you would say Medicaid is primarily about taking care of pregnant young women who are poor and their children, often single parents, many times on state assistance. If you're in an emergency room, on the other hand, they would say that Medicaid is the place where the folks who are living in the homeless shelter across from our hotel down the street come for their chronic care. These are folks that are homeless by definition. They are often afflicted with mental illness, drug and alcohol abuse. A third category of patients that are prevalent in Medicare is the so-called dual eligibles, those folks that have both Medicare and Medicaid, and we'd find those in Oregon anyway in nursing homes as they've become poor enough to qualify for Medicaid, but they still have Medicare as their provider, as their main providers for health insurance, and a lot of the cancer policies are driven by that. And then the last category is really the category that this plan was designed to help expand, and that's the working poor, the folks that the checking at the grocery store, the folks pumping gas, the folks that have an income but they don't have enough to make to have health insurance. The other thing that's important to know about Medicaid is that the tools that we've been talking about today, like coinsurance, like formularies, these are, at least in Oregon, are not available as tools to help us manage utilization. And that's because this group is so vulnerable. And so the Oregon Health Plan is really a story that began back in the late 80s. It turns out there was a legislation passed that would forbid the coverage of bone marrow transplants for patients on our version of Medicaid. Not long after, a young boy named Kobe Howard was diagnosed with acute leukemia, which was very treatable and curable with transplant. He was eligible for Oregon Medicaid, but he was refused coverage. There was efforts to raise money to cover his transplant, but he died before that could happen. That resulted in a legislative proposal to put transplant coverage back into the Oregon Medicaid package, and this was opposed by John Kitzhaber, who at the time was an ER physician and a state senator, and has since been a three-term governor in our state. That legislation ultimately failed, but in the aftermath, a reorganization of funding priorities, ultimately labeled the Oregon Health Plan, emerged. And so, in general, the Oregon Health Plan is really not designed to be like most other versions of Medicaid. The goal is health rather than insurance. We had a public input process that unfolded in the late 80s and early 90s to help drive this plan, and included input from all stakeholders. But the key thing that makes this different is that budget constraints were to be met by reducing benefits rather than cutting people or reducing payments below the cost of delivering care. And even so, today, Oregon Medicaid is a horribly poor payer, and in fact, access remains an issue despite the fact reimbursement rates are so low. We prioritize coverage using the best evidence of clinical effectiveness. We maintain integrity of the prioritization by prohibiting legislative changes. So we can't have legislators taking pet projects and pushing them through Congress. Instead, we use this Health Services Commission to help figure this out. And the whole goal was to expand coverage to a larger population of the working poor by funding only the most effective therapies. And the key take-home here, though, is there was no guaranteed coverage for all standard therapies. Here we go. So out of this legislation came a so-called list of prioritized services, and I think many people are vaguely familiar with the Oregon list. And this list was developed by consensus with expert opinions in the early 90s. It's overseen by a group called the Oregon Health Service Commission, which now is called the Health Evidence Review Commission. And what it does is it lists from top to bottom treatment pairs based on this expert opinion panel of effectiveness. And what a treatment pair is that, for instance, line 50 on the list is coarctation of the aorta. And what you see there is the ICD-9 code for that diagnosis, and the CPT, which is surgical correction of that. And so those two pairs are put on a line, and then based on the evidence of how well it works, that line is categorized as to being highly or less highly effective. There's a total of 679 lines, the last one being gastrointestinal conditions with no or minimally effective treatments. And actually our colleagues in GI have requested that they change that they don't not want to be seen as on the bottom of the list. The funding line right now, well, actually the line has changed a little bit. This is a little bit outdated, but recently the funding line was 502 or higher, which is Bartholin's cysts and the treatment for that. In 2006, shortly after I was asked to join this group, there was a reorganization process. As a result of incremental changes of the list over the first 10 years or so of its life, things got a little goofy, and there was prioritizations that didn't make as much sense. And these general principles were used to kind of reorganize the whole list. And a more disciplined manner of scoring the lines was developed as well. But this really reflects the triple aim priorities of the Oregon Health Plan, which is to cover primary and secondary prevention and chronic disease management at a high level. We called out a specific line for comfort care. Cancer would fall into Category 6, fatal conditions with a focus on cure or disease modification. And you can see at the bottom there's other categories. Now, just because Category 6 is ranked lower than, say, chronic disease management, it doesn't mean, for instance, that cancer treatments wouldn't be categorized in certain situations higher than certain chronic disease. For instance, how did cancer fare with this scoring process? And I think the sniff test here for us turned out reasonably well. With a funding line at 500, ALL, childhood ALL treatment, and AML transplant, you can see it around 101, 102. Testicular cancer at 123, colon cancer at 167, breast cancer at 197, myeloma at 198. So, most of our colleagues in oncology say we think you got it right as far as scoring of the lines. But there was one caveat that we were saddled with from the very beginning of the plan, and that's that these lines had a specification that said cancer treatments are covered when the treatments were associated with a greater than 5% 5-year survival. In essence, administratively, this was really only prioritizing cancer treatments that were focused on cure, although the bar was set for pretty low for cure. Despite that, fact, this was kind of under the radar for the first 10 years or so of the life of the plan. And the reason for that was, as we've heard, there are no codes, there are no ICD-9 codes that associate prognosis or stage with the disease. In the early stages, there were bigger fish to fry. In fact, a lot of the Medicaid was organized according to, or at least was being delivered by health plans that were struggling on how to keep people out of ER and how to make sure they were paying for the right services for pregnant women. Back in those days, relatively speaking, it seemed like it wasn't worth the hassle. 5-FU and leucovorin for colon cancer, it just didn't seem like it was worth going after that. And generally speaking, incurable cancer was not seen as a big cost in a plan that was covering a lot of pregnant women and poor children. However, as we've seen over this whole day, that cancer became a much bigger target as the costs were rising, routinely on the top 5 in health plan cost rankings, and the escalation was happening at an unsustainable rate. In addition, because we were successful, I think, in including more working poor in the plan itself, the health plan administrators were seeing more cases of cancer. There was also increasing evidence that the cancer spend was occurring disproportionately in the last 6 months of life, where it would obviously not be of greatest value. And the managed care plans that administer most of the Oregon Medicaid came to the Health Service Commission and said, we think this is worthy of tackling. And so at the same time we reprioritized the list in 2006, we formed a task force to address that. The task force was a challenging process at first. One of the problems we have with Medicaid in general is that it's not, at least if you're outside of an urban center, it's not something that comprises a high percentage of any oncologist practice. So most of the oncologists in the state had less than 5% Medicaid. So getting a medical oncologist interested in trying to solve this problem was a bit difficult. We did surveys, and the limited survey responses we got back said, by the oncologists said this is worthy of dealing with, and they agreed that there is a lot of wasted care at the end of life. But I didn't have very many volunteer to participate in that task force. What I did have was some internists. I had medical plan directors. I had palliative care and social work people that showed up. And the first thing that happened was the palliative care people called out and said, we don't think palliative care belongs in the same discussion as paying for chemotherapy near the end of life. And we basically decided they had us at hello. And so we called out the palliative care is always covered. That those questions are really not tied to whether chemotherapy is useful or not. And it should be covered whether the patient is considered curable or not. And patients with a terminal illness considering chemo should have palliative care consult whenever possible. And we were a little bit proud to have implemented that at a time several years before Dr. Temmel's article was published. The palliative care people also said we see one of the biggest barriers into getting our services delivered is the implementation of marginally or ineffective chemotherapy near the end of life. They saw this as a false hope. We saw, and as Mike pointed out, we saw the emergence of drugs like for renal cell cancer where there was statistically significant but perhaps clinically insignificant improvements in survival that were getting FDA approval. And they said, you really ought to focus on that. So we said, help us think about a formula that would do that. And they looked at us and said, knock yourself out, and basically excused themselves from the process. And so what came out of this was a so-called Guideline Note 12. And so instead of changing the way the whole list works, what we do is apply a guideline over the specified lines. And so for all the cancer lines, this Guideline Note 12 was written to direct those medical plan directors. They can actually approve care beyond what the list would cover if they choose to. But if they're going to deny care, they have to use the list as their justification to do so. And so this would provide the roadmap for a medical plan director working for Medicaid to deny care. And these were some of the concepts we use. One of the things that we called out is that we really wanted to try and draw a circle around care where almost every oncologist would say, you're right, that's not the best use of our dollars. We wanted to also call out the fact that patients with poor performance status are not likely to benefit. We wanted to create a tiered approach to coverage depending on how long the patient was going to live with therapy. And we actually wanted to recognize the fact that we were fixing a hole, because prior to this, technically nobody in the Oregon Health Plan had coverage, and nobody with incurable cancer had coverage for any treatments. But the thing that we were using to guide us is that when we spend money here unwisely, the result is that somebody else is not, perhaps people even with curable cancer are not going to get coverage at all. And although we don't tend to use the word rationing, I mean, when you have zero ability to expand coverage or expand dollars, then you really are trying to decide where to put that money. So this guideline note says that the plan would not cover service for patients with any of the following. If your life expectancy with treatment was less than 6 months, there was pretty good evidence that hospice was a better way to serve you. At the very bottom, we said, if your life expectancy with treatment is over 24 months, this guideline doesn't apply. In other words, anybody who's going to get 2 years of life with treatment is covered. But then between 6 months and 2 years of treatment, we tried to write a guideline that would say, if treatment was going to get you a survival of 6 to 12 months, the treatment had to improve overall survival by about 50%. And the goal was to exclude coverage for marginally effective drugs that might add 2, 3, 4 weeks of life to somebody who only had 6 months. And then if your median survival was 12 to 24 months, we lowered the bar and said only a 30% overall survival improvement was required. So, challenges. Well, one of the first challenges, which isn't on this slide, was that shortly after this was implemented, one of the health plan, one of the enlightened individuals at one of the health plan got a request for erlotinib in a patient who was a heavy smoker, 62-year-old woman who'd failed 2 or 3 lines of previous chemotherapy. And these were in the days before we knew just how predictive EGFR testing would be. So the study suggested she was not likely to respond, and the plan, in its wisdom, sent out a letter saying, we can't cover you based on the new rules for the Oregon Health Plan, but you are eligible for assisted suicide. And so we asked, why, of all the services that you would have covered, why did you put that one in there? But of course, that got a lot of national press and attention. But the bigger problems in terms of implementation was that not every situation has a randomized clinical trial. And as we've heard today, increasingly progression-free survival was used as an FDA approval mechanism rather than overall survival. But the biggest problem is that there's crossover in almost all these trials. And so overall survival was very difficult. An interesting situation, for instance, was the fact that carbotaxol, which had become generic about that time, was very affordable and reasonably effective, but it didn't actually meet the criteria for survival. But when you added Avastin, after Dr. Sandler's article was published, now it did. So we were actually going to have coverage for a 3-drug program that cost a lot more than a 2-drug program, and the incremental benefit wasn't really there. But the biggest reason that we had to readdress this was because of the Affordable Care Act, which non-discriminatory provisions in that act said that treatment decisions can't be based on life expectancy. And while it did call for an expansion of Medicaid with new federal dollars, there's still equal pressure to save money in the implementation of Medicaid so that we can sustainably afford that expansion. So we had another task force that convened last year, and that task force was much better attended. There was a lot more public input. There was basically statements of principle, and a lot of what we went through was basically trying to say that what this council was looking at was, and our values were really consistent with what most people would say are reasonable goals for cancer treatments that are not focused on cure. We talked about access to peer-reviewed trials. We actually talked about comprehensive multidisciplinary approach. None of this is really a guideline. This is just trying to say we get it. The guideline itself, though, says that now treatment with intent to prolong survival is not covered if you have progressive metastatic cancer and severe comorbidities unrelated to the cancer. In other words, if you are really if you never would have qualified for the studies that the oncologist was using to justify the treatment in the first place, then we wouldn't cover that here either. And or if you had a decline of performance status associated with the treatment. In other words, patients who anybody could see as not doing well with therapy would be ineligible for coverage here. We actually called out that intent to relieve symptoms or improve quality of life is a covered service, and we actually leaned a little bit on NCCN and other guidelines, although most of us who work in this world would say that the guidelines aren't specific enough to really give them a lot of teeth. And we also wanted to make sure there was evidence of goals of care discussion in the chart, and that's something that the medical directors felt was very helpful. Sorry, I guess maybe our batteries are dying here. All right, so lessons learned as we get to the end here. One of the first things is that this discussion is colored by strong emotions. Of course, when you're drawing a circle around treatment is going to be administered near the end of life, that can create a lot of emotions, and we didn't do that on purpose. We were saddled with that because of the way the list was originally written, and that 5% 5-year survival was written in there. So we were trying to fix that. We heard from patient advocates who told us, and some advocacy groups who said that there should be no role for the state or the health care plans to define what should be done near the end of life. Their position was that this should be between the doctor and the patient, and there's really no role for us to be legislating any of that. We heard from the medical directors that they thought that the old plan, while it was difficult to implement, had value. Making doctors show their math was something that they thought was very valuable. Even though they ended up approving many of the requests, it was interesting to see behaviors change over time as doctors had to show the math. The physicians that were polled, I guess I would say they privately told me that they liked having some backup. There were plenty of times where patients were in a situation and they knew that further treatment wasn't going to help. but the patients just didn't want to get it, and it was nice to have an administrative barrier there to actually help stop that, but I couldn't get any of those docs to say that in public. We actually have consensus on value definition is lacking, and we applaud the work that's going on at ASCO. That would have made this job so much easier. But even if ASCO does a great job, I think we're still going to have challenges if the patient advocacy teams are not on board with what that value proposition is. We've still got to work for published evidence to be structured in a manner that's better than it is today. Hematologic malignancies was a big problem, and in fact, we're actually working on a separate guideline for heme malignancies. The downward trajectory of those folks, even with highly curable disease, is such that they would technically not be eligible for treatment even when they are curable, and so we're looking at that as a whole different animal. The discussion did bring the community together in some respects. Oregon is a little bit different in that it's not that big, and it wasn't that hard to get people together to talk. There were a number of creative solutions that came out, mostly in how we fund palliative care. And Medicaid was out there, some of the Medicaid health plans were out there funding a lot of palliative care initiatives that were really not fundable through traditional insurance because of the discussion that we started here. And the last thing I wanted to say was that I think really what we learned out of this was these are discussions that I think are going to be mirrored if we really get risk sharing in an accountable care organization. I think behind doors, this is the kind of discussion that's going to be going on, because instead of it being tax dollars, it's going to be a pot of money that doctors and hospitals are going to have to divvy up. And when we heard from bariatric surgeons who were held to the same level of standard evidence, when we heard from folks talking about tubes in the ears or what hernias should be covered, and they didn't like the idea that we were putting any limits on them. We usually use it as a tool. We said, well, what would you take out of the list in order to make room for your hernia surgeries? And it's amazing how many times they point at oncology care near the end of life and say it's the biggest waste. And so I do think that if we're sharing risks together in affordable care, accountable care organizations, that dynamic is going to show up again. And I think perhaps we can learn a little bit from how we had tackled this problem. Thank you.